Oops.
I'm Karen Cole, I'm IDD care coordinator for Mary. Kathy Rader, family member. Jeff Vice Carroll. Michelle Harper, IDD care coordination supervisor in Buffalo County. Diane Dahl, provider. Sonia Pitts, executive director of Open Hearts Arts.
Ronnie Payne, IDD care coordination manager of Buffalo County.
And Lynn English is also here. She's outside directing people down a very long hallway to this room. So we'll go now to Boone.
Oh, you missed him.
Oh, I'm sorry. We got two more here.
I'm Jane Lindsay, I'm with the CFAC committee, and I'm individual.
Okay, sorry about that, y'all. Boone?
I'm Roger Miles, Home Care Management Corporation. I can't see the camera.
Yes, over.
Running as well, they that white. And I'm also in the,
My name is Kelsey Bozeman. I work for Turning Point Services, and I'm an EC teacher in Utah County.
I'm Christy Pruitt. I'm the IDD Care Coordination Director for Smoky.
Tina Clark, I'm an IDD care coordination manager for Smoky.
Lorraine Reminger with RHA.
Sydney Myers, RHA.
Deborah Cannon, IDD coordinator regional.
Joanne Prossett with Turning Point Services. Christy Lofton, Time Opportunity.
You're good. Christy was last.
Okay, we'll move on to Lenore.
Hi Jesse, I am John Fraser. I'm the IDD care coordination manager for the Central Region.
Hi, Mary Short and Katie Short.
And that's all of us here in Lenore.
Okay, we'll move on to Silva.
Emily Gaddis with MCH. Linda Beck Calvin, disability partners. Kathy Beals, care coordinator.
Robin Van Wy, IDD Clinical Director.
Susanna Bowden, IDD care coordination manager.
And Jesse, I just want to say that I'll be
Yeah.
taking the notes, and if everyone can make sure that they have signed in, because that's where we're going to get our roll call.
Thanks, Robin. So I'll reiterate, make sure you signed in. Because it's true. And then when you sign in, please try to be legible about it, because it's hard to decipher the names sometimes. Anyways, let's see. The agenda. Tonight we will review the action items. We have a care coordination presentation by Christy Pruitt. We'll touch on the fact that we've had some committee resignations and brief discussion about home and community-based services, transition plan, more information about the state level stakeholders meetings, our webpage. I'll briefly discuss the Cardinal settlement, even though all the folks that requested that be on the agenda aren't here.
I'm here.
Rather, we'll make any announcements. When we made 9
It's okay.
the entire agenda, it was a very full one, and we just have 2 hours. And this is an end-on-time meeting.
Cool.
It may not be a start-on-time meeting, but it's an end-on-time meeting. So, does anyone want to try to add something to the agenda, or want to go ahead and remove something? Okay, I'll take silence as approval of the agenda, and then we'll move straight into the action items. Well, yes, I need a motion to approve the minutes. Okay. All right. And then scrolling through the minutes, we've changed our meeting date till today. Maybe that's why our attendance is down some. We got the flyer updated and emailed out. And I hope y'all are continuing to send feedback I added the Cardinal settlement to this meeting, even though we may not get to it tonight. So all of those items were addressed.
Is the card gonna put that back up?
It affects the entire state, and that it's just clarity about how we're expected to communicate the process rights and rules around the labor. So, yes, it is important, and the DMA, DHHS as a whole has been providing certain trainings for MCOs to ensure that some of the parts of the class actions that occurred in the Cardinal will not occur in other places in the state. And we can touch on that closer in the meeting. I would like to move on to the care coordination piece because we have Christy Phyllis with us, and she's prepared this for you. I know she needs to be somewhere else in a little while because she has a 9-year-old daughter who's celebrating her birthday. So I want to get her on through. So Christy, I'm going to broadcast your PowerPoint, so you will have to tell me when to move forward, okay? Are you there?
Okay, yes, yes.
Can you see your PowerPoint? Hello?
Okay, we're okay, all right, we're good. Yes,
Can you see your
I
PowerPoint?
can, but I also have a copy for myself, and then you guys all have them.
You just need to tell me. I'm trying my best to stay on the right slide.
Well, so you can go ahead and switch to the second slide, and it should,
Oh. Let's see. Let me try to make you bigger, Christy.
Yeah.
you don't have to do that.
Her screen will enlarge as she talks, so.
And here's me, I'm right here.
Well,
But as you
you
guys,
should be coming up as the person speaking.
I said it would take about 3 minutes for it to switch over, is what Jason said.
Oh, so she'll switch it there. Okay, you're already getting a little bit bigger. Okay.
I won't take that personally, Jesse, thank you.
Don't take it personally.
All right, so my name is Christy Pruitt. Like I said, I'm the IDD Care Coordination Director for Smoky. My office is actually based in Boone, but I travel to all 23 of our counties. We were asked to do a presentation on what care coordination is for the stakeholders group. So we put together just a PowerPoint to kind of give you a visual of what it is. I believe it's in your packet that you have in front of you, so you can follow along with it. In each of the rooms, you have a care coordination manager there, and some places too. So I will look to them to answer questions as well. So just kind of be thinking about questions as you have them. So the first slide is, what is care coordination? Because care coordination is different than target case management. Care coordination is focused on the individual as a part of a population, which is different than target case management, which is focused on the individual, period. Care coordination promotes the correct diagnosis and effective treatment, efficient use of resources. We work to prevent recidivism, and we monitor for care, for a person's care. And we look at it as a whole picture. We look at it in the context of all of the life domains, the behavioral health, facilitative, medical, dental, social. We try to look at it as the bigger picture. It facilitates access for high-risk populations. We try to make sure that those individuals, if we can connect them to a Medicaid service, we will do that. Thank you. Our core responsibility is care coordination is an administrative function, meaning that we don't bill for any services that we provide. It's an administrative function. I will give you, up on the screen, you see the 6 functions of it, and each slide subsequent will talk a little bit about what those are. So it's identification, assessment, planning, referral and linkage, monitoring, and then disease and risk management. you have any questions so far? Okay, we'll keep going. So care coordination, next slide, Jesse, please. There we go. I'm sure you guys have seen this before.
I'm going to interrupt, sorry, the delay was actually me, not the technology. We have a question in Asheville. That's what did the delay.
Thank you. To ensure access, does that mean to get access if the individual cannot?
It means that to ensure access, that the person gets the services that they need. We don't transport, we don't make appointments. What we do is we work with our provider network to create the access to the services. This is the place where we might see a service gap, where we need someone to do a certain service, where we might need our providers to do evaluations or behavioral support plans, which we know that in particular is a gap in our service array right now. So it's to ensure access to the right amount of service. So if we don't have it, we work with different departments to create it.
So if an individual can't get something, it's up to a care coordinator to help get it for them. As far as services.
Did you hear that?
Yeah, I did. And it's not care coordination alone because if it's not there, we can't get it. So what we do is we work with the different departments in Smoky, like Provider Network. If there's a certain service that Medicaid under the waiver pays for, not state plan Medicaid, but under the waiver, then we work with Network to create, or to work with a provider to create that service. But there's a difference.
Aren't you also supposed to link, care coordinator link services together with other Medicaid services?
We do, but that doesn't mean that we we don't have control over the state Medicaid providers.
I know.
Yeah, so we would link a consumer, we would link an individual to that provider, and that's about what we do. We link them to that provider. Yeah, it's not state plan. Yeah, it's just
Medical and then, I mean.
yeah, Medicaid services. So that's what we work towards, to ensure access to the right amount, duration, and intensity of service for the individuals that we serve, while reducing escalating costs as well as improving consumer outcomes. It's not just about cutting costs, it's about making sure that we have quality services in place. Care coordination alone is not responsible for all of that, but the MCO has a lot of different departments in place to help improve consumer outcomes, and we all work together to make that happen. So the next slide, we talked about what care coordination should be. It should be consumer focused. Jane, I think this is one of your questions, that we act as an information hub between agencies and systems, part of the linking and referring, and we share information with those different agencies and systems. We do coordinate an integrated service plan to the best of our ability, because we also know that we do link to different medical and dental and other Medicaid services, if at all possible. We work to ensure the development of a crisis plan with individuals' team. Again, that's not care coordination alone, but we work to pull everyone together. We focus on understanding the needs and successes of the individuals that we serve so that we can put that into an integrated plan. And then, of course, we monitor services and celebrate successes with the individuals and their families or legally responsible persons. We want to sing the praises of all the success that happens from the waiver. So our first responsibility is identification, and we do that within a couple of different ways. So right now, care coordination utilizes our MIS department to identify target populations and flag for care coordination. So we run a couple of different reports called our top 20% of costs. So those are individuals whose services are in the top 20% of Medicaid spend. A lot of those top 20% are for individuals with IDD are actually in ICF homes. And care coordination we don't do care coordination for individuals in ICF, that's an all-inclusive service. We do that with our high-risk, high-cost populations for individuals who have 3 or more crisis services in a rolling year. We provide care coordination to. We also provide care coordination to individuals who don't meet any of that criteria if we think that there's something that we can do to help connect them to services. Because a lot of individuals that get referred don't necessarily meet those identified target pops. And then, of course, anyone who is on the Innovations waiver, which is the C part of the waiver, qualifies for care coordination and they get care coordination. We try to be proactive in our identification by tracking the high utilizing individuals, and we work with providers to do that. Community Care of North Carolina also shares data with us so that we can identify individuals from them. They have their own criteria, and then the MCOs have our criteria. And then we're one of the few MCOs who take external referrals. We take referrals from providers, DSS, school systems, families. So our referral process is open, and it's not a closed process. So the next slide. Core responsibility number 2 is assessment. Care coordination may do some of this, but we also are responsible for connecting individuals to that, such as if they need a psychological evaluation or something like that, or something to help ensure that they are connected to appropriate services, we make that connection. Within care coordination, we do have the support intensity scale assessment that we have a team of staff who do those. And they do those on individuals on the Innovations waiver right now. Care coordinators, as you know, also do the risk support needs assessments prior to the individual service plan. If a person is dually diagnosed, they may have a mental health care coordinator or a mental health provider do a locus or a CalLocus, which is the mental health systems assessment tool to identify a level of care. As well as a comprehensive clinical assessment. Outpatient providers, most specifically our CABAs, do comprehensive clinical assessments which help determine what a person needs, and that helps guide the planning process. So it's important to understand that according to the waiver, an individual has to have an IDD diagnosis that is documented prior to the age of 21. Most frequently, we get that from the school systems, from school psychologicals, and that helps us with that. And then we are able, if a person doesn't have that, then we try to get them connected to someone to get that, or we request school records to help us determine the documentation. Any questions? I don't want to be going too fast.
How are you linked with NC START?
NC START is a service within, it's a service that's offered to the entire state. There's 3 regions. So care coordination, or anybody actually for that matter, can make a referral to NC START. They provide crisis intervention services. They do, if a person is in the ED, they will either do a phone consultation or sometimes they can go out and see the person while they're in the ED. We do complete referrals for NC START to serve an individual. They are kind of maxed out though. So right now they aren't really serving any new consumers. They're just serving the ones that are on their current caseload. We have sometimes gotten people into their crisis respite. They also have planned respite. They have a 4-bed home in Statesville. 2 beds are for crisis respite and 2 beds are for planned respite. The planned respite is pretty planned out. It's pretty far out in advance. We continue to refer people to the crisis respite, and we just wait till they call us and tell us that the person can come. What they aren't able to do for us, unfortunately, though, is usually take someone in the day we refer. They're not going to come in and offer us to. I don't think that's ever happened. They don't take someone who doesn't want to go. They don't take someone who doesn't want to go, nor do they take someone who doesn't So they will not take a person who doesn't have a place to be discharged back to. We continue to work with NC Start. Jenny, Smokey we have a pretty good working relationship with NC Start. We try to, Robin Benwine and I and Gypsy, we have monthly phone calls with the NC Start coordinator, Michelle Clutch. The care coordinator provides me with information about things that are working and not working, and we talk about that during that monthly phone call so that we can kind of work through some of the stuff that we're experiencing. We have told them multiple times about the need to have another crisis home, and I know you guys know that.
Nope.
They work really hard to work with us, and they just actually got the national accreditation, so they're doing a lot of good things. And
And I think it's always important to point out that NC Start is not sufficiently funded.
that's true.
It just hasn't been since its inception.
Who's it associated with?
Right, we have three, RHA does it in our area and out east, and Easter Seals does it in the central region. Is that correct? And it's a program that was developed by Joan Beasley, and it was rolled out in North Carolina around 2010. And as is typical in North Carolina, we really wanted the program, but we didn't want to pay for it. So we negotiated with Dr. Beasley to create something that was a little less than what she felt that it should be. And as a result, we're trying to figure out ways to fully fund START to enhance the crisis continuum in the state so that it would improve the quality of services all the way around, because that's a necessity to maintain successful home community-based services. So right now, START is at full capacity, and we're merely talking with them and trying to find ways to get additional funding. I know there's discussions at the state level about additional funding going to LMEs for NC Start also. So that's part of the history.
Yeah, and it should be noted too, for our region, they serve Smoky, 23 counties as well as Mecklenburg, and then, partners.
Yeah, partners and Mecklenburg, so.
Yeah, so they serve 36 counties, 23 are ours, and then, for 37.
And you have a very small team our catchment area is 9,500 square miles. You throw in partners and a couple of the others, and you're talking about pretty much the whole western part of the state for a very small team. So, okay.
I think our conversations monthly with Michelle, that's always helpful, and Christina is always actively involved, and she likes to know what's going on, because she really wants to develop that relationship and provide that service. So the
It
next
has
thing
demonstrated success in other states. I'm sorry.
No, you're fine. Okay, so the next thing that care coordination does is we work around service planning. The individual service plan develops a plan for what the person needs. It's in conjunction with the team. It's not care coordination alone. However, care coordination does maintain individual support plans for consumers on the waiver. They typically call a team together of the individuals that the person has identified that they want to be their support team, and then they create the document that really tells the team and the provider or whoever picks that up about that person. And within that is a crisis plan that's developed, again, with the team. Care coordination can't do it alone, and it's important that the crisis plan be followed if it's created within the team. And that's always hard to plan, because individuals, a crisis is different for everyone. So you're trying to work with the team to figure out what the crisis is for that particular person. Requires a lot of conversation. Is it a behavioral health crisis? Is it a medical crisis? What kind of crisis is it that would make us create the right kind of crisis plan for that person? And again, that has to be talked about in the team. We assist in coordinating services across the health system and with other systems, including primary care. A person on the waiver has access to any mental health services that they also qualify for. And so if that is identified, then care coordination, IDD care coordination will then work with mental health care coordination to connect them to a comprehensive provider to meet the mental health needs. We also are trying really hard to ensure that people have a primary care physician as we're moving forward towards whole person care. We do have some individuals who don't have a primary care physician, and we want to try to make that connection. And then we also, as a part of service planning, we measure results, including reduction in unnecessary utilization or catastrophic events, and improve consumer outcomes. So we look at a lot of data to see if the plan really improves a person's life based on the services they're receiving.
I have a question.
Christy, we've got a question in Lenore.
Back under the previous slide, where it says measure results, including reduction in unnecessary utilization or catastrophic events and improving consumer outcomes. For who? I mean, so what happens to the information that you've measured? Is that, I mean, really, what? I mean, you say you're measuring improving consumer outcomes, so where does that information go? Where does that measure go?
We have to turn stuff into the division as we are trying to increase our, service provision and quality service provision. We work with, some of those results go to our provider networks to help us create, and it also goes to our clinical UPMs, so that we can look at the services offered and the services provided to determine if a person actually needs more services based on their outcomes. Go ahead.
And there's also the performance outcome measures that we have to report to the division that's gathered from the treatment planning piece. There's about 23 measures, aren't there?
28.
28 measures. And some of those are not specific. Those are typically things along the lines as the plan was completed in a timely manner, the plan captured what the person wanted in the plan, and now is it perfect? It's not completely perfect, but the score is if the guardian signs the plan, it suggests that they're in agreement with the plan, and they have the places on the plan to indicate that they're not, and that's captured too in the data we gather. Is if someone's saying,
how many people do you think understand what they're signing in that plan?
Well, I don't know the answer to that question. It's our responsibility to share the information with them, and
I want Jesse to see.
possible to make sure they understand it.
Well, but Jesse,
It's just hearing.
well, Jesse or Christy, I understand there are performance measures that are a part of the waiver document, and I've read and seen Smokey's response to those performance measures, and it's actually pretty hysterically funny to read because one of the measures, like Jesse just said, is that the plan includes that all of my needs are met. My needs are met by this plan. But that doesn't then measure, there's no measure for those denials. So I submitted a plan that met my needs, but you didn't approve a plan that met my needs. So that led us all through the appeals process. So this idea that, I'm just trying to understand where these measures and this improving consumer outcomes, none of this is ever told to the actual consumer. These are all just MCO administrative functions. No?
Well, in terms of what you were saying, where you said you went through the appeals process, all of that stuff is a part of those measures. They look at that as well, to help the MCO and to help guide the system. I know that's not exactly what you want to hear, but that is how.
Well, but like I said, I read the performance measures that were submitted, and it said that it was 100% the plans met the consumer's needs. I mean, we complained to the board of directors about how the performance measures weren't really accurate. Nothing, of course, was done, but I just think this group, as an innovation stakeholder group, should be aware that these measures, this data is being collected and reported, and it isn't the truth. And unless you go to board meetings, and unless you go to the quality improvement, or whatever that group is, whatever that committee meeting is on board days, and you see that document, or you go to the board section, the board of directors section of the website, and look up the documents that were provided at the board of directors meeting, you never would have access to that information. So I think this group, if you're really going to be an innovation stakeholders group, you need to have a better understanding of what these measures mean and how they're being reported.
Mary, I think that's a very valid point.
Thank you, Jesse.
As part of this committee, we can use it for that education piece, and we can do a presentation here about how that information is calculated and the direction that the state gives us in calculating that data.
And how that data is gotten to the consumer or their
It's
bank.
Right, would you?
Well, all the consumers can raise their hand right now and tell you they've never seen it.
Okay. We will share it. We will bring it to, our next meeting is June, when is our next meeting? June 29th?
I have June 1st and then June 29th.
Trail, so
It's June 1st.
it's June what?
June 1st.
June 1st. Oh, shoot, I didn't
Yeah,
schedule
it's
it for a long trip.
This is the April meeting that was postponed, and then the May meeting is June
Okay.
1st. June meeting
All right,
is
so
June.
in the May meeting on June 1st, we will do a presentation about quality, about the measures, the performance measures
I'm
that
muted,
the
so
state
if you
expects
need
us
to jump
to
back in, let me
report.
know.
Yeah.
And I know that this has been a topic in the state stakeholders meeting too.
And I think part of that was the reason for this meeting today is for, after your explanation that in 2016, so much was going to depend on the plan of care. And so that's part of the reason for this meeting was to decide the care coordinator and the individual, but they needed to be in that plan.
Yes. Okay.
What it needed.
Yeah, and I agree, and we will share that, what we have with you, okay? So,
They are looking at changing some of those performance measures, aren't they, Nancy?
Eliminating them.
they're talking about them, but, you know, the funny thing is it's one of those areas that's very hard to understand because of the way it's set up.
I don't think
Would you
so.
agree, Lynn?
I do agree, and those performance measures were actually set by CMS. So the CMS to the state and then to us, with very little direction on what the meaning and intent is.
And their performance measures are constantly changing and will be more in line, hopefully, with some of the home and community-based service standards. So, okay.
Those are emailed to us, and we have no part.
So when you're in the ISD meeting, you'll talk about crisis planning?
Like, we get the crisis plans and an email that we get like, the risk assessment, the budget, schedule. Never have I been a part of a crisis plan.
Okay, well, we will make sure we address that with the managers. Yeah, I appreciate that.
Because she's, of course, is the only person that's happened to. What an idiot. I'm sorry.
Well, Christie saying that she's going to address that with the managers, that's us, so that
Okay,
it'll go
the
out
next
all the way around.
responsibility is, this is what you're talking about, Jay.
Because that's not
referral and
acceptable.
linkage. So IDD care coordination assists the family in choosing providers, and when I say that we assist, basically what we do is we work with our provider network to tell families of providers in their area who provide the care or provide the services that they are looking at. We do this not only for Innovations waiver services, but we also do it for specialty services, such as psychological evaluations, connections to primary care, and other medically related appointments. So neuropsychologicals, dental, the things I'm mentioning to you, I know are kind of difficult to make connections to. But care coordination is trying to look at a bigger picture now, and so if we see that a person needs primary care, we will make the connection either to CCNC or somewhere else to help get them connected to primary care. I have been on committees where we talked about the need for dental services for individuals with IDD. I say that just about every time I go somewhere, just looking for someone to step up and say, we'll do this. That seems to be few and far between, but it doesn't stop us from acknowledging that we need that. We inform and coordinate referrals to providers for other behavioral services, like I mentioned before. If a person is fully diagnosed, we work to try to connect them to a behavioral health provider or mental health provider. Because again, even though a person is on the innovations waiver, it doesn't mean that they do not have access to other mental health services. And our job is to get them connected to whatever services they qualify for. If a person wants to do self-directed services but needs some assistance with that, the care coordinator can work, and typically it's a Jesse, I'll just say that, with appointing a representative to assist that person in self-directed services. And then we also work with the individuals on if they want to work towards employer record.
I have a question.
Managing employer services. So that's our EOR services.
We have a question here, hold on, Christie. We've got a question here, Christie.
Excuse me, but isn't the community guide the person who helps with the self-direction of services and the employer of record managing?
They offer the training to the families if they want to pursue that. Care coordination will give the individual and legally responsible person the list of community guide providers that are able to offer the training for those particular services.
But it's required that the community guide.
Yeah. Mm-hmm.
Thank you.
Do you have any providers in North Region or community guide?
Well, in GT independent, we'll also do it. Mm-hmm.
We have recognized that community guide is a gap in our network.
No
And
kidding.
We're doing some different things about community guide.
That's not a surprise.
Because we're going to try
We know
to
that.
utilize it through B3 more, what's the right word, more aggressively, so that we may find providers that feel they can actually offer the service and it be sustainable, because we want to tie it to some B3 services for folks that aren't on the waiver also. And we have a series of meetings with provider stakeholders following our regional provider advisory councils coming up in May, where we will be brainstorming with providers for them to identify some of the roadblocks or barriers that they see in the system that's preventing the utilization of B3 services, because we have this B3 dollar that we could be using to serve folks that do not have anything. And, tying community guide, B3 community guide, to waiver community guide in some manner, and those B3 respite services, and possibly some other services that we could request from the DMA, could lead to increased utilization and increased network of providers. But that's all down the road a little bit. The positive is that we are talking about it, and we're going to have some brainstorming sessions and divisions giving us the opportunity to explore our options. B3 services, in managed care, you have the 1915B waiver and the 1915C waiver. The C waiver is innovations. The B waiver is your mental health and your substance use disorder services. Well, one of the sections of the B waiver is B3, and that section allows a managed care organization to create services that are not otherwise in the state Medicaid plan. Like section B1, B2 are all about services that are in the state plan. B3 services that are not in the state plan, and that allows us to create other alternative service definitions. However, the DMA, the Division of Medical Assistance, hasn't been very forthcoming with alternative service definitions. They've given us peer support for mental health and substance use, and they've given us community guide and B3 respite for IDD. So, what's that? And supported employment. We do have supported employment now. And there's some other services we can add to that array that would more directly impact persons with intellectual and developmental disabilities. But we do have the supported employment option, which is one that I often forget. So, that's something that we'll be talking about more in the future, because after we go through these brainstorming sessions with providers, we're going to look to offer some real ideas about how we can increase access to these services for folks that are on our wait list. And in turn, that will help with the need for community guide through our catchment area. Okay.
Is there any discussion or movement for peer support for the IBD population?
There's discussion. I don't know that there's any real movement. Okay.
Yeah,
Sorry about
we
that.
have talked about that. Oh, no, that's fine. The peer support for IDD, we've talked about that at different levels. Like Jesse said, it just hasn't gained any momentum. I think we've even looked statewide or nationwide to see if anybody's actually done it, so that we can see if it can be replicated. But that's a state thing. That's not just us.
Right, and there's a group exploring supported employment internally to increase IDD use of that service too, because there is a huge expectation that people start transitioning into work instead of historic day programming. Okay.
Do you have a question, Michael?
I was just getting ready to say we can plan it if we can find some.
There's just so many regulations around peer support. Like through the state definition. It has to meet certain criteria for it to be peer support. So I don't disagree with you.
And that's one thing about peer support's not really ever been a part of the DD array because of advocacy organizations that already exist in the DD world. And peer support is a lot of advocacy and guiding the system. And in ways, community guide, that's what the purpose of community guide is. Like in a really ideal world, you would have community guide employees of agencies that are family members that have helped people navigate the system in the past. That's what I would think a community guide would be ideal for, but that's just my thinking. So, let's see. We'll go back to the presentation now, unless there's any other questions.
So the next slide is continuing referring and linking. Regardless of whether a person does self-direction, care coordination still provides the basic supports for individuals doing self-direction or employer of record. We're still involved. IDD care coordination has an already identified caseload that, like I mentioned earlier, is comprised of individuals that are on the innovations waiver. That statement is in the slide because IDD care coordination caseloads are more static, whereas mental health substance use caseloads are very fluid, change more frequently than individuals on our caseloads. We also serve, like I mentioned earlier, individuals who are not on the innovations waiver who may qualify through either special healthcare needs, which is they're Medicaid funded and they meet certain criteria, like they have unidentified IDD diagnosis prior to the age of 21, and we can connect them to a Medicaid service. And then, of course, we also serve individuals, like I said, if their first service is a crisis service, or if they've been in the emergency department 3 times in the last year. And it's a rolling year, so it just kind of changes. And an individual will, if they are an innovations participant, they only come off of an IDD care coordinator's caseload in the event that they pass away or they transfer to another NCO, and we transfer them, or if they move out of state. And sometimes their level of care changes, meaning they go up a higher level. They may end up in a skilled nursing facility. They may end up in Black Mountain or Riddle for an extended period of time. If they end up in a state developmental center, just for you to know as well, care coordination also has Olmsted care coordinators who work with individuals at J. Iverson Riddle and Murdoch Center, as well as Caswell Center. And if a person is identified from a community ICS as ready to step down into the community, we refer to one of our Olmsted care coordinators to help get them connected to community services and out of that level of care. So our Olmsted care coordinators are also a part of the care coordination department. All right, there you go. So one of our biggest responsibilities is monitoring of the services provided to an individual with IDD. We monitor the implementation of services as outlined in the ISP. So what has been developed through the ISP, the services where they're provided, and the number of hours, something the care coordinator does. We review and monitor records. We are required to monitor claims. If a person has a relative providing the services, we have to monitor those services face-to-face monthly. If they live in a residential treatment facility, we have to monitor those monthly. If a person is new to the waiver, for the first 6 months they're on the waiver, we're required to monitor that person in their setting monthly. And then our job is to try to make sure that the person has access to all the services that they need based on an assessment that they've had. We work with providers regarding backup staffing, making sure that that's identified on the plan. We look at issues of health and safety. We provide choice of providers. If there are more than one provider for a particular service, of course, non-waiver needs, I've said that before. If a person needs to be connected to something that's not a part of the waiver, we try to get them connected to that. And again, there's that trending of state performance measures. We look at those and we use that to try to make care coordination services better. We do use the information that we have. We share it with the managers, so we share it with the staff, and we try to increase our care coordination services. So on the next slide, I kind of already went over all of that with you guys. Those are services and monitoring services that we're supposed to do face-to-face. And we actually, Jesse, what is our actual number of innovations participants?
15 something.
You're muted. Your mouth is moving, but we hear nothing.
We have 1,647 slots. Did you hear that?
Yes.
Okay.
And that's over our 23 counties. And so quite a few of those individuals either have a relative providing services or they live in a residential treatment, which includes AFLs. And if a person lives in an AFL, then we do go and monitor that AFL monthly too. So care coordinators are out and about a lot doing these face-to-face visits. In different locations, we provide those face-to-face visits where the services are provided.
Chris, do we have a question?
Yes, my question is, how and when do you monitor the respite that is provided to an individual? And then why is it that I and the families I know personally can't get a monitoring visit outside of normal business hours Monday through Friday? Why aren't care coordinators doing this face-to-face monthly visit on a weekend or in an evening? And how and when do you monitor the respite?
I would say we do actually have care coordinators who monitor after hours and all. Yeah. So it does happen.
And if an individual requests it, is that simply supposed to be honored?
Well, we work to ensure, I mean, we're not going to come out after, like, if a service is provided at midnight and that's the only time, we would work with the family and the care coordinator to do that, if that's the only time the service is provided. We try to make the monitoring visits as least disruptive as possible.
So if it's least disruptive on a Saturday at 11 a.m., why is that not?
We could work with Steve, talk about that request for that monitoring visit.
And again, respite. I have had a number of families in the last couple of years. It's not just recently, but the last couple of years, they've been concerned that their adult goes to the home of the respite provider and never once over the course of the years they've been using this family as a respite provider, has anyone ever monitored the respite service? So is that something a family, because if you're monitoring face-to-face, if a family is a provider, a family member is providing services, so you would monitor that family member, but are you also then monitoring the day supports program or the supported employment? But why is there no monitoring of the respite?
There is the expectation.
Yeah.
There is the expectation with respite that if the person's providing respite in their own home, so the person goes to the home, the provider is expected to go and do a review of that home. And, yeah, and respite sometimes is monitored, I would guess, but more often than not, it's probably not monitored by the care coordinator as often as some of the other services. But the provider is expected to provide that monthly.
Well, but we're talking about care coordination.
Yes.
Well, Brett's not scheduled, and so we don't know if that's being provided.
Oh my God.
That's right.
Just trying to make the point that we're hung out to dry. Just trying to make the point that we're hung out to dry because nobody's monitoring it. So if you all don't see that as a gap in care coordination, then you don't see it. Okay, I get it. Point taken. Thanks for playing.
Chrissy, back to you.
Next slide, please. Okay. So we talked about the monitoring activities. We also ensure that at least one service is utilized monthly. That has now changed to where it can be respite as the only service that's utilized monthly. We are to ensure that services do not exceed the authorization that the provider has been approved for. And that the participants' needs are met and that updates in the level of care or the ISP occur in a timely fashion when a request is made. All of that is weighed upon, then the care coordinator has to work very closely with their caseload. Then the next one, which is another responsibility, is we look at risk management and disease management. We we work to identify key health and environmental risk factors that might impact individuals with IDD. We try to manage care across the continuum promotion with the person, the provider, and other payers to improve outcomes. We look at focusing on individuals and at-risk populations to achieve improved outcomes. We try to provide education and information for an individual's needs if they have a certain diagnosis. We can work to try to provide them education on how best to work with that. If they're diabetic, we can connect them to one of our RNs to provide some education on making sure that they take care of those needs. Thank you. Appreciate that. Something that care coordination also does within Smoky, we do provide a clinical infrastructure within Smoky that ties into a larger support system. Smoky Mountain is the only NCO that has licensed managers and licensed directors. We use the manager's license to help with any kind of clinical needs that a person has, so that we can truly make sure that we are using our staff to the best of our ability and making sure that we are trying to take care of the whole person. We do work with the team to ensure whole person care. Like I mentioned earlier, Smoky has now hired RN care coordinators that can be used to work with an individual who meets the criteria that have high medical needs. We do strive to build on natural supports that are already in place. That's what we want to work with. And then build on those. We also work with other departments within Smoky. Care coordination is not the only department. We work with our clinical department. We work with provider network. We work with community collaboration, which has our crisis staff in there, our hospital liaisons. And we work with quality improvement. We do have a quality improvement project going on right now that we are working to try to make sure that we are doing, making sure that we are connecting diagnoses with medication that a person is on. And then we work in partnership with our periodic and residential providers to ensure service delivery. We do work with our providers regarding service gaps, and we don't do that within care coordination. We do that through provider network and the conversations they have with our providers to help with our service gaps. Been asking questions, so I'll just keep asking them, but I also, on your PowerPoint, I listed who the IDD care coordination staff are. I did not list all of the care coordinators, but there's the managers, and I put what region they serve, if you need that. And I did not put the on-site care coordinators on there, but I could fill y'all in real quick. In the Buncombe area, we cover Buncombe, Henderson, Transylvania, and Rutherford Polk. That's Jen Branham. She's the on-site care coordinator for that. For the western counties, the 7 western counties, that's Ginger Parker. And for the northern and the central counties, it's Sharon Kellerman. And most of y'all probably worked with them or talked to them at some point.
Could you say the first one?
Jen Branham. And I will say, this is not a part of this presentation, but I will say that Smoky, as a part of the Money Follows the Person program, I will say that our, out of the 30 slots that they use every year to try to transition people out of state developmental centers, Smoky transitioned 22 people into the community. And so that's something that we're really excited about, because we got people out of institutions and back into the community of their choice.
Was that 22 in the last year?
Mm-hmm.
Now 30?
Well, in 2015, yeah. Out of 30 slots, but I think that's the MFP's, like, what is that word I'm looking for? That's the goal. 30 is the goal, yeah.
The 22 mental health SA over there.
They were IDD. They came from either state developmental centers like J. Emerson Riddle or Murdoch Center, or a community ICF.
Mental health SA.
We didn't train, well, I take that back. Some of those individuals, through Money Policy, the person came out of PRTF, Psychiatric Residential Treatment Facility, so they are children that are dually diagnosed. But to get MFP, their primary diagnosis has to be IDD. So that's how we would count them.
Any other questions?
Okay, one more.
Okay.
We have one more, Jesse.
Okay, I'll ask one more, Jesse. Incident reports. What is the care coordinator's role in incident reports that a service provider might submit? Be it because of backup staffing or maybe a behavior incident or an injury incident. What's the care coordination role?
If we find out that something has occurred, we remind the provider to file an incident report. We don't file them, the provider does file them. And we might get notified. The provider will tell us sometimes, and if not, then we can go to our quality improvement department and we can ask them to check if we hear of an incident occur.
And we do get, Chris, to get reports on backup staffing.
If,
Yeah, we do
if there's
get
any,
reports.
yeah, quality and integrity receives the incident reports, and anytime, anything beyond level 1 incident is reported to the care coordinator or to provider monitoring for a review. So it doesn't all lie with care coordination. And then also the backup staffing, when there's patterns recognized for one client, the care coordinator is notified of those reports.
Thank you.
Is to review what?
We didn't hear
Y'all want to speak to that? When the care coordinator is monitoring records in the provider's office, could you share what they look at?
We look at notes, we look at what's in their, we look at their claims, what else on their progress summary, data sheets. Medications.
Any type of doctor visits?
You just look at the entire record. Whatever the provider has in the record is what they look at.
Short-term goals. There's more of a technical guide that shows you everything they're supposed to know.
So it's, really clear.
Actually,
They have to see incident reports and they also agree that like you suggested, there's a backup staff problem, they'll ask to see or send in incident reports on that also. So they do a good job.
here's the checklist that care coordinators use when they come.
Oh, there you go. You can find it.
But it's in the technical guide.
And here's the general monitoring that's done typically by a care coordinator.
Did you send that to us?
Yeah, I can include the link in the next email I send out. It's on the,
Mhm.
it's easily accessed at the SMC Innovations page under forms. It's the very bottom form. Extra monitoring, provider review, it shows you the things that we're expected to look at in each circumstance.
That's an Excel.
Agency reports is also for EOR.
Yes.
That's an Excel form, Jesse. Not everybody has Excel. So if you send the link,
Convert it to PDF.
okay, just saying.
Yeah, I should be able to convert it to PDF.
Thank you.
You have to convert all of them. 6 months a day, you have to convert all of them.
Yeah. Convert each sheet, we can do that.
And does this group, we were just having this discussion here, does this group already have a copy of clinical coverage policy
Yeah, it's been sent before.
AT? Okay.
We're muted again.
I think it'd be real helpful. I don't know how the care coordinator could go out and inform a family of what really needed to be in there and stop a lot of the fluff and make it more clinical. Because you're gonna have people looking at, I don't care if Susie likes music. That's nice. And it could be a goal that's being built on, but unless you put the clinical in there, of really what's wrong with the individual, if they're going to base in 2016 the funding on what the individual needs, then it needs to be clinical to know the needs of the individual.
Well, the funding,
You have been talking about this for about 10
the funding, is going to be tied to assessments, not the plan so much. And just because the assessment suggests that a person's supposed to be in a funding range doesn't mean they're absolutely limited to that funding range. So it's going to be more of a, the supports intensity scale assessment identifies a level of need that has a funding allocation attached to it based on a comparison of other people in the state. And then that funding allocation, the care coordinator will show up at the meeting saying, we anticipate your services be within this funding range. And then the team's going to sit down and develop a service plan, ideally, that stays within that funding range. If the team does not feel that the service, that funding range is sufficient to meet the person's needs, they can still request services in excess of that funding range. But the whole concept is that utilization management or care management, that department is going to review the plan to make sure that the bare necessities are present on the front end. But then there will be reviews to make sure that everything's occurring as progresses. So the way it should be, it should be a little bit, I like, instead of you being handed a menu without any type of budget or account or anything, you're handed a budget and you pick out the menus, the menu items within what you're allocated if it's sufficient. If it's not sufficient, you still have the right to ask in excess.
Is there a max amount?
The maximum in the waiver currently is $135,000, and it may be $135,000 in the new waiver. There will be a solid limit somewhere because that's required by CMS, and there's no way the legislature would let us send an open-ended waiver to CMS. Yeah, because they already just give us $61,000 for the $135,000 limit, and that may have been cut slightly too. So,
Did we ever figure out how many people, what percentage of people were in ICFs compared to the innovations?
The average cost in an ICF in our area is roughly $113,000
States though,
per person.
in the state a lot higher.
State developmental centers is roughly, no, that's pretty much statewide for ICFs. Some ICFs in more metropolitan areas are more expensive. The developmental centers are the most expensive, ranging up to $175,000 a year per person. The way the way managed care works is Smoky Mountain's given a per member per month from the Division of Medical Assistance, and that is roughly about $61,000 per person that's on the waiver. So we have some people that we're receiving $61,000 for, but it just costs $20,000 to serve. We have some people that we're receiving $61,000 for, and it costs $120,000 to serve. So that's why it's a little bit of a shell game. And the idea behind resource allocation is for the state to get a better picture of where the money has to go. That's the reason that Smokey's made the decision to move forward with completing SIS assessments. So we have a better idea of the needs in our catchment area. So that's all part.
And we also do that through a critical case staffing process. For some of the questions around an ICF placement, whether it be community or state developmental center, before a person actually applies for a state developmental center, we put them through a critical case staffing process to make sure that we've tried all the services that we can try in the community to keep them out of that level of care. Just for your information, that any placement in an ICF is considered short-term, and when I say that, like Jay Iverson, individuals are put under an MOA, which means after a year we're supposed to look at whether or not we extend it or we bring them back. Nobody can go into Riddle and live there anymore. We now have long-term placements and then MOA placements.
Yes. Anyone that goes in now has that memorandum of agreement with Smokey and J. Iverson Riddle or Murdoch Center that we will be able to get them out, find them a placement within a year. If a person goes in one of the 2-year programs like Murdoch, we have to provide funding to ensure that they get out also. So it's not the lifetime placement that it used to be. There's still people that have been there a lifetime. There's also the ICF community, or the community-based ICFs. There's you're seeing people transition through them more too. So it's but that's a systems piece that we got to figure out too. That is like, it was a comment that ICS do not get as many referrals as they used to. And that's partly just because of the evolution of the system. You know, historically, that was the best we had to offer, and a lot of families now, that's not acceptable.
They're complaining they don't see that.
Yeah. Right. And it's not because of anything that setting's doing. It's just, it's different, and it seems still segregating to families that have been integrated in the school system for their entire lives. So it's an evolution of the system. So, Christy, you need to go get some Chick-fil-A sandwiches. That's where her daughter wanted to go for her birthday.
Because she gets a treat.
Yeah. I'm awfully fond of Chick-fil-A sandwiches with lots of mayonnaise and pickles. Maybe I'll have to make a trip after this meeting. Thank you.
Thank you.
Okay, we'll move on to our next agenda item. I did pretty good. We should supposed to get out to 7, but we just go over a little bit. The next item on our agenda is committee resignations. And of course, as we can all tell, our attendance is dropping off. We've had a few folks step out, and I had a lot of people say that they couldn't come because of the date change by email. But I've had 3 folks that are listed as committee members. Dakota no longer wants to participate because he finds the meetings rather dry and boring. He basically said to his mother, "Do I really have to do this?" So, and that just took 2 visits. And then Paige Jeffley, she was a provider representative out in the West. She actually took a job with Smokey. So we'll have to find a replacement for her. And then Amy Sills-Jones, a provider representative from the Central Region, also fills this better for some of our other staff personnel. So I'm going to send out a new email between now and the next one asking for additional applicants. And folks that haven't attended a meeting over the last 3 months, I'm going to kind of send them a notice saying that if you're not going to attend, we need to add someone that wants to attend. So we need to be proactive with that. And we are coming up on a year anyway. So those pieces will occur. Any objections to those actions that I plan to take?
Actually, big vote.
Yes.
You did.
Oh, no, we don't today. So I guess that makes it a dictatorship, doesn't it? It's consensus. I just can't be a dictator about it. Okay, do I have consensus with that?
Sure.
It makes sense, doesn't it?
It makes sense.
Because we always should have those here that are really involved that want to be. Okay, let's see. We're going to talk some about the Home Community Services Final Rule homepage and the transition plan. You're going to hear me talk about this ad nauseum. I'm going to forewarn you. I may drive some of you to saying, oh, these meetings are incredibly boring and I'm going to quit too. That's after all my goal. And I minimize my, I minimized the, let me find this. JHS. There we go. So here's the home page for the Home and Community-Based Services Final Rule. And this is going to be a system over the next 5 years. The plan was submitted on March 12th of this year to CMS, and there is the expectation that persons living in residential placements or receiving home and community-based services have as much community involvement as is possible. So this impacts residential supports, day supports, and supported employment in our Innovations Way. The first step of this transition plan is a provider self-assessment. You can't figure out where to go if you don't know where you are. So that's the purpose of this self-assessment. And that self-assessment pilot is starting. The kickoff is actually going to be May 8th in Winston-Salem because we'll be meeting with, I think it's 73 providers statewide that are going to be doing this assessment, this self-assessment. The training happens in Winston-Salem for those providers. I know some people in this room will be at that presentation. And it's going to be reviewing the self-assessment tool, the philosophy behind the self-assessment, what we'll be looking for, what the person should be looking for when they're assessing their own services. And the self-assessments will be completed. They're actually going to be completed on this electronic form that creates mineable data so that we can review the data and determine where the real trouble spots are in our system. And the example that I've been using because it's the easiest example is, in my opinion, it's the easy example. A person that lives in a 6-bed group home and receives residential supports, they should have a key to their room and they should have a key to the house. They should be given the opportunity to use that key and they should know how to use that key if they're able. If they're not able to use that key, there should be efforts in their plan to teach them how to use the key. That kind of thing should exist. There's also going to be the expectation that a person that's living in a residential placement be given tenancy rights as they are outlined in the state. So that drastically changes some of the things that we see happen in residential placements, where they say,
take them and drop them off at the emergency room. Well, as you're giving someone tenancy rights, that's their home. It's kind of a shift in the system in that where the person lives, the person with disabilities, guess what? They have the same rights as I do when I'm renting a piece of property. That's the thinking behind this. They think that they have the same rights as any of us when they're living or renting a room, because their money's just as good as our money. And their monies that they get through Social Security and special assistance is paying for that room. Yes. So those are the kind of things that this is shifting the philosophy in the system. The self-assessment's going to give us a picture of where North Carolina stands. And hopefully providers will be really honest in assessing their current circumstance. That's what we're going to encourage. Because if you're not addressing some of these things, you'll be able to tell us your plan to correct these things and how you plan to correct it. Like the issue with the key, it could just be changing your policies to ensure that it's discussed at each team meeting. So,
Jason?
Yes.
About the tenancy agreements, does it address, North Carolina law, tenancy agreements go both ways. You can require, security deposits, you can be required to pay for property that is destroyed if people have tenancy agreements. Will those be addressed?
Well, that's what, those same issues, or those same comments, we sent that to CMS. We're waiting for clarification from CMS regarding those pieces. And at the NC Tide conference Wednesday morning, that question came up, and the response was that we had not received the feedback from CMS.
How do you get money out of the term? My kids spent 4 days in the Harvey holding tank, and they sent him a $1,500 bill. He says, "What are you want my lawnmower?" They didn't, but he tried. So there's no way to get, it sounds good, but there's no way to get money out of IDT. Most of them anyway.
Well, it makes sense as to why a person with Medicaid would get a $1,500 bill.
Because in the holding ER, they don't, the insurance, the Medicaid doesn't cover the psychiatric. It's not covered, yeah, it's not covered, so he got the bill and they sent him to collections, so he's wondered, there's not somebody there. He thinks so, yeah.
Okay.
Well, safety issue, like if one of the tenants has a key and might give it to somebody.
Well, you see, if there's safety issues, those kind of things have to be explained and explored in the plan. It's not just because the person has the right to have the key doesn't mean that they necessarily are capable of having the key. So what you would have to do is address whether or not they need the key in the planning. It's paying attention to the things and not automatically assuming that, because one thing we tend to do is we staff to the lowest common denominator in a home. And I say that.
I have a question.
You've got people in a 6-bed home that don't require awake overnight staff, but they have that staff because someone in that home does require that. And so you have people in a home that can't have a key because of certain circumstances where you need that key. But you have people that are perfectly capable of having that key. But what programs and systems tend to do is they set the rule tied to the person that can't have the key. And that's what this is trying to stop.
But you didn't answer that.
Jesse, we got a question here, Lenore.
But this is Mary Short. Jesse, you didn't answer that. So Katie cannot be given a key, clearly. But if someone else in the home is allowed to have a key, so Katie's rights trump the other person's rights? Or does the other person's rights trump Katie's rights? It's like the whole idea of being allowed visitors at any time of the day or night, and how does that trump Katie's rights?
No.
Well, it's not trumping her rights, it has to be considered for each person.
No.
It's going to be a very person-specific thing.
No.
With each review.
No,
and the best part of this for you is it's not going to impact Katie at all because she doesn't receive residential supports.
Well, and that's because when she does, she's going to decline waiver services and get the ICFMR to which she is entitled because it is a state plan service, even though it's an optional state plan, and she cannot be denied her ICFMR placement because she gets to choose that.
Okay. And that's her choice.
I can see it would be complicated in a group setting, though.
It's going to be very complicated in the group setting.
You've got somebody who...
A lot of bad things are going to happen.
Whose room is next door to somebody who's medicated to sleep. That's going to be...
Well, but now let's step back and think about this. There's going to be rules in any home that you live in, any household. I live in the city limits. I can't have a party after 10 o'clock.
No.
But you can have someone sleep over.
No.
Yes, I could.
But not if you live in my house.
Well, but it's going to be very complicated. That's why I say we're going to talk about this ad nauseum.
They should have the rights based on forgetting they have a disability, then what are their rights? Don't start with a disability.
And you know, and one good example that was shared is like, say a person wants to get up in the middle of the night and have a cookie. They aren't capable of getting up in the middle of the night to have a cookie. You don't have to get them up just because they say they want a cookie. Does that make sense?
No.
You have to figure into the person's abilities too.
Well, that's not fair.
So you don't just have free reign.
But that's not what Janet's saying. You start this way and work backwards. So I want a damn cookie.
Well, and that's why I started this whole conversation was this is going to be a huge system shift.
In fact, I can't get out of bed.
Well, but if you can't get out of bed, that's a limitation that exists in your life.
So I would get a cookie. Oh,
Not until the morning.
But you can keep the cookies in your bedroom.
Yeah, you could keep the cookies to where you could reach them. Unless the team meets and discusses it, and you can't put a bag of cookies in front of you because you'll eat all of them.
But then okay, so here's another example. So, Thomas informs me at 27, he is a man and he can have as much soda and as many Red Bulls as he wants, regardless of the fact that the psychiatrist says the cocktail of medications that keep you on this planet don't really do a good job with that. What wins?
The guardian.
But I can get
It's complicated, the team would have to discuss it. The whole key is that the team discusses it, and that the person's rights are considered, and if it's determined that you're restricting the person's rights in any ways, it's outlined in the plan as to why you're restricting the person's rights.
So the really good isn't why they have certain restrictions, it's what they
But his opinion on what he should have and the team's opinion on what he should have are two very different things.
Who's Thomas's guardian?
Well, his mother is, unfortunately. And he wants guardianship back, but he can't figure out how to get it.
situations that even exist in a regular hospital. In our hospital, we may have a 25-year-old who comes in and he's had a spinal cord injury. He's very, very angry, which is very typical, and his life is just drastically changed, and he refuses wound care. He refuses medication. I mean, there are certain things that we will say, bottom line, for us to be responsible for you here, these are the minimum requirements that you have to comply with as far as being part of the patient. Right.
Times it been beneficial to the point of, I don't be residential because of the activity program, but some sometimes our participants might come in and they have this big activity plan, but one participant had behaviors that day, so they couldn't go, so it affected all of them rather than just me. So it might be something that can work out issues.
It should work out those issues.
I think that's,
But that's the kind of thing it wants to stop happening. Yeah. Any thoughts about this in Boone?
I do have one.
Sorry. Yeah, that's a good question. Will following, regulations be considered restricting patient rights now?
Would you repeat that once more? I didn't, it broke up a little bit.
Following medical recommendations, doctor's orders be considered restricting rights?
I think it will, I can't say a broad stroke yes to that. It just has to be looked at in each circumstance. And these home and community-based standards will just be applying to a set of services, residential supports, day supports, and supported employment services that are used in group settings. And the concept isn't so much about restrictions as it is ensuring that the person's including the community.
I mean, I get what you're saying, Dusty, but they'll change the operational definition to include every medical decision as restricting patient rights, or percentages of restricting patient rights in North Carolina is going to skyrocket.
Yeah, and I don't think that's the intent.
I know, it's not the intent, but it will be seen as a very restrictive place for people if we change the operational definition to include that.
Hey, Jesse, do you mind if I address that for a second? 'Cause the way that I have, this is
Someone else to answer.
this is John Fraser in Lenore. The way that I've always addressed that with folks that ask that question is to relate it to a doctor visit maybe of myself. And I go and the doctor says, look, your diabetes is getting a little out of control and you need, and here's what my recommendation from the doctor is, here's the order, no more sodas, no more cookies, whether at midnight or not, no more sweets. As an adult, I have a right to follow that order, or I have a right to ignore that order and go against it. And that's the same thing with a doctor's order to someone, say in a group home. If we tell them, no, the doctor said you can't have a soda and take that away from them, that can be seen as a rights restriction.
I get that, but if we change the operational definition, it will statistically skyrocket the number of restricted patient rights we will have throughout the region of the state. I get what you're saying, I get how it could be used that way, and I get that maybe it does need to be changed, but it has to be accounted for. Else you're just going to take one thing and have it be.
And I think John's philosophy is a great one.
I do too.
But at the same time, we have to, as providers, we have to deal with Division of Health Service regulation. And I can see a lot of backlash for just like what you said, John. If they're adults and they should be able to make that decision, but if they ended up getting sick or hurt because of that decision, it's the provider who is going to be the person that pays that.
Yeah.
That's discrimination, that's what I feel like it is. So,
Yeah, I'm going to have to ask, anytime the discussion is not occurring in your area, that you mute the phone, because we get a lot of echo when more than one phone is active. And I do understand the Division of Health and Service Regulation concerns, and that topic is being considered also, and that's part of the purpose of the self-assessment, is to identify the parts that providers see a conflict between the DHSR rules and the HCBS standards, because there's going to be several, because DHSR requires that it be a locked facility sometimes, or certain regulations that don't jive with the HCBS regulations. So where this is ultimately going is just the expectation that we see more and more community-based settings away from congregate living arrangements.
Be
Okay.
monitored. Oops, sorry. Don't the exclusions have to be monitored or reviewed every 90 days too?
Well, that's, I believe, as far as exclusions, are you talking about rights exclusions or restrictions?
Right, so somebody can't have a key for whatever reason, isn't that supposed to be reviewed every 90 days?
That may be one of the outcomes. I can't say for certain at this
God,
point.
I hope not.
A lot of it would
Can
depend
you
on-
imagine every 90 days having to review why Katie doesn't have a key?
Sometimes it's just ensuring that.
This isn't about getting services to Katie, it's about employing bureaucrats. Plus, it's going to drive providers out of the business.
We had that discussion,
So that's gonna be a big deal too.
I can't recall it.
I expect we're gonna have.
They're going to drive providers out of business.
That's serious.
Because like she said, they're not going to take the risk.
Yes.
well, there's ways to
What
look
we're
at
missing is that it has to start with what the individual wants. There's going to be a lot of people who don't want a key. There's going to be a lot of people who don't want a door lock. And so that's really where it has to start. If they want those things, that's very different. But there's just going to be a lot of people, it wouldn't matter to me if I had a bedroom door lock. But it may matter to Kathy. So there's a whole lot of things that we really can't just generalize and say, everyone gets a key. It's going to have to start with what they want and then go back to that whole person-centered thinking of balancing what's important to and what's important for the person.
That's an excellent point, Robin. And I think it's a good one to end this conversation on. Starting with the person.
And I'm sorry,
Yeah.
can I say, well, I understand what
Sure.
Robin's saying, I think that's great, but what if you have a guardian who says, yeah, I want you to have a key, and, you know, I want you to have this right, and then the guardian, or the person next to him says, that's endangering my person. I mean, it's a whole big, it's not gonna be simple. And I think you're gonna have different people's rights restricted regardless if it's you having your rights restricted, then the person next to you might have their rights restricted because of your rights. Does that make sense at all?
Yeah, it
And
makes
I think
perfect
it
sense.
goes back to what Missy said, we're going to see less congregated living environments. You're going to be, with the self-assessment, you're going to see more.
Very cautious about.
But you're doing nothing to keep them in their own homes.
Excuse me,
Well, as I'm muted. Go ahead, Michael.
I want to believe that, and I'm not gonna go into no names, but I see it a lot.
What do you see a lot of? People getting their rights restricted?
A lot of people getting their rights restricted, which they shouldn't be doing that. I mean, I'm sorry, but that's the way I feel. I mean,
Absolutely.
the whole, it's a whole new complicated restrictions.
It absolutely is.
Pretty interesting.
And that's a great point, and it goes back to what Robin said about person-centeredness. And a large part of the training around the HCBS is really considering person-centered thinking and the planning for the person. So I think that, as I said, we'll be talking about this again in less than 30 days. It's been discussed some at those meetings, not as much.
Oh, yeah, the discussion's long from the Lord.
We'll move on to the next topic. Let's do the state level stakeholders meetings. Service definitions continue to be presented at this group
They've reviewed the majority of the definitions. I think they're down to just 6 that they have not presented. The website for the state stakeholders meeting is way behind.
Yes.
They haven't updated any information since January, and I think that's because of about the amount of feedback that folks are still getting regarding the definitions. Some of the primary changes that I know have occurred in discussion, and this is beyond just language changes, because all the definitions are being changed in a manner to try to capture the character of home and community-based services, comparable language and intent at the first of the definition, but then considering different limitations. There's discussion now about changing it to where residential providers are responsible for transportation to day supports programs, because that ties it much more into the way, Smokey doesn't come and pick me up and bring me here.
Yes, they
No, that's never happened. And anytime I go somewhere else, and then I might have to deduct my mileage. So you know, that's more in line with the way a real job works or a real day activity works in most settings.
It's already being done.
In some counties, because of the rural settings, the way things are, it's already being done that way, right?
Our AFLs would provide the transportation for
Because who does the day program, the day program means a lot to the AFL provider too.
They're usually going somewhere anyway.
So that's one big change. There's still discussion. It's a given that AFLs are going to receive respite in some manner. It's just how's that respite going to be built into the service array. That hasn't been clarified yet, but AFLs, one person AFLs, and for sure possibly the licensed AFLs. Not so certain about the licensed AFLs.
One person AFL?
Mm-hmm.
Oh, you mean one?
One resident. But it's likely there'll be some type of respite in AFL situations because it's supposed to be alternative family. And, you know, if a person's living with their family, they get respite. So that's kind of the thinking there.
So that would come through community support though, where they would have us, community support worker like I have, who would come to the home to provide respite, as opposed to making resident go somewhere.
Well, in the, what's being proposed in the definition is that if the person wants to go to the respite worker's home, that can occur. That's going to be allowable by what's being discussed. So like, you know, just like if...
It's just not an institutional setting.
Right, right.
You made a statement that meant like families did. Many families don't get paid for providing services like AFLs do either.
That's true. That's true. They don't. But some families are paid to provide services. So, you know, it's an alternative family living setting. The person, it's still a group. It's in North Carolina, it's a group home for one person. If it's unlicensed, it's that funny. And the way our rules read. But, you know, it's still not congregate living. And it's, people have been burning out since they don't get breaks. And the provider structure doesn't really, the rate structure didn't really allow for enough of a break. So I'm not sure how it will work out, but there will be some mechanism for the provider to get a break and still be in their own home. As in, the person could go somewhere else for a couple days.
If you have it specifically for that licensed homes won't get breaks?
They haven't said specifically that licensed AFLs will not get breaks. But that's
That's some of the discussion. I think the last reading I saw, it was all AFLs could get a break from care. The waiver is going to have a supervised living definition that allows people that need 24-hour care in some way to live in their own homes. So basically, it's creating a day rate for people that that are living in their own place, not a family home, but their own place. And
But not for those that need more than 12 hours. So if you're living at home and you have needs of 12 hours,
yeah, you see, you're going to have, it's going to break folks into categories of lives with their family, lives in a provider home, or lives in their own home. And people that are living in their own home would be eligible to receive supported living. People that are living in the provider-operated home would be receiving residential supports. And people that are living in their family home would be receiving some type of periodic mix of services.
there's still a limit of 12 hours.
There would still be the limit of 12 hours a day, at my last understanding, but there's mechanisms to exceed that as it's needed.
But if something happened to me, and Andy was in the home alone, I mean, he was perfectly comfortable at home, but couldn't be left alone at night, he would shift into that category of living in his own home.
You could
have somebody that would spend the night.
You could leave, you could set it up to where your home goes as trust to Andy. And then there's a service available where he could continue to live there.
But he would have to be the owner.
It would have to be his place in some manner, yes.
There's different places to that legally.
He could be in a life state.
You could rent a home.
Yeah, you could rent a place too. He could be renting his own place too.
His name's on the deed, or
It's considered his place, not your place. If that makes any sense. It was confusing to me in the debates around it because I felt that you could create you could use the community supported living definition and have periodic rates and day rates, but that's not.
you can almost do it now. So
You have to be too creative to do it now, but yeah, but that's really the only change that I can think of beyond the resource allocation pieces that will be communicated in depth as the waiver is rolled out. Dave Richards said at NC Tide that it's still the goal for this waiver to be submitted by the, I think, the 1st of July with a targeted date of implementation date, January 1. That might be delayed slightly. Because there's talk at the legislature about adding another waiver, another seed waiver that has a $20,000 limit. So it's like supports waiver part 2. And then, of course, what the legislature decides to do with regard to funding is which direction to go. Because the legislature is putting a lot of pressure with the expectation that there be more predictability in waiver services. That pretty much sums it up. Any thoughts in actual beyond what's already been shared?
One thing, when you say lives with the family and it's a supported living type funding, that's not similar to the home supports that they used to have, right?
No, the home supports would still be like a person that's living with their family would be receiving community living supports. Residential supports would be available in the provider home. Supported living would be available in the person's home. And the person's home is differentiated from the family home is that they're not living with parents or brothers or siblings, that kind of thing.
Say the three again, residential, community living.
Community living supports and supported living and residential supports. And that, I'm still not certain that those are the set names.
Supported living is you live on your own.
Your own apartment, house, your name on a deed or lease.
Yeah, you are the leasee, you're responsible for the household.
Community support is with your family.
Right.
And work, well, there would be workers and the family that, some family provides services, and you got workers that come in.
Yes, community living supports could be provided by family members that lived in the same home. Supported living, not necessarily. I'm not sure what the decision will be about that either, because a lot depends on which box gets checked. Any other thoughts, comments in Asheville? Okay, any thoughts about the waiver development in Boone?
Doesn't look like it, really.
How about in Silva?
We're fine, Jesse, thank you.
How about in Lenore?
Yes, hi, this is Mary Short. At the last state stakeholders meeting in Raleigh, which was last Friday, I forget, there was a discussion on the limit on sets of services. And the clarification that appendix, what is it, C-4, limits on sets of services, is actually a dollar limit. It's not an hourly limit that is to be applied to limits. And I informed Mr. Richards and Ms. Gouda as loudly as I possibly could about the fact that I have had conversations with CMS in Atlanta about the fact that our current waiver has these hours in that appendix as the limit on sets of services, and CMS in Atlanta could not tell me how it got approved as it is written, and the people who did approve it are no longer with CMS. So CMS is clearly alerted to the fact that Appendix C-4 limit on sets of services is a dollar limit. If we are all going, and in fact, Kenny Howard, the person at CMS assigned to the 1915 C waivers in North Carolina, Kenny Howard was very clear in her opinion that CMS would not approve an hourly limit on sets of services, and to her specifically, it doesn't make sense to have an hourly limit on sets of services if we are all assigned budget categories, because the budget is our limit on services, our individual budget categories. So there's quite a lot that has to do with work that still has to be done around this so-called limit on sets of services and how it's going to play going forward. And it makes writing these service definitions and posting them for public comment, because it is the goal of the state stakeholders group to post these service definitions for public comment. But if it doesn't include information about limit on sets of services, then they're going to run into a big problem. There was also quite a discussion on the community guide service definition, and the way it is currently written, the community guide service would include payment for yoga classes, the actual payment for the yoga class that an individual would want to attend. And the discussion again, got quite heated on the idea that taxpayer dollars are going to pay for yoga lessons for an individual on the waiver while we have a waiting list of 10,000 people trying to get any waiver services. Shouldn't the payment for those yoga classes be something the individual pays for or something that is provided through charity? But how do you justify using rare Medicaid dollars to pay for yoga classes when you have 10,000 individuals on a waiting list? So it got quite heated. I haven't posted the video to my YouTube site yet. That's on the agenda for tomorrow. And that's all I have to. Uh-huh.
Good information.
Once you get back to the community guide with the pay for yoga classes.
Actually, I think it was attached to community networking,
Oh, okay.
because I remember the debate about that service definition too, before it got to that group. Mhm. And I did not recommend that it pay for yoga.
And all this confusion that we're sitting here listening to is going to be the CMS by July 1st.
I'm done.
I'm so confused there. I mean, if they were functioning at CMS, it wouldn't be confusing here.
Oh, there you go.
It's,
Thank you. I mean, they don't have that across the board.
it will eventually get to CMS. July 1's a target date. It started a year ago.
But we have to remember that we haven't ever had this opportunity to give input, so that part is.
There's a lot more feedback opportunity than there's ever been.
And firstly, I don't know how you weigh yoga against the woodworking class that Thomas took that he didn't like, but yet it turned into a 15-hour-a-week supported employment job sharpening blades, and Medicaid pays for the stitches.
Well, yeah, it's a tough call. Well, what's medically necessary, what's not. And some of the idea is a lot's going to rely on resource allocation and working efficiently. Let's see, we need to get to, we've been everywhere.
And it's 8.
Oh, and it's 8 o'clock. This is an end-on-time meeting. We'll carry over certain items to next time, which is June 1st. We'll meet for our May meeting in June. We're looking at the schedule. Thanks, everyone.
Thanks, Jesse.